Good afternoon. Welcome to Hopkins at Home. My name is Nick Rowan. I'm an assistant professor within the Department of Otolaryngology, Head and Neck Surgery. I'd like to thank Hopkins at Home for having me here today to talk to you about what is hopefully a relevant discussion for everybody. Although I am a clinician, this is something that has been intimate to all of our lives over the past year and a half plus, and that's smell dysfunction or olfactory dysfunction in the setting of COVID-19. Today, first of all, I have no disclosures. We're a clinical trial site for a sinus medication. However, we have no funding or other relevant disclosures for this talk. And today, I've got 3 objectives for our talk. And basically, I want to review with you the importance of smell loss in the setting of COVID-19. So first off, I'd like to talk about why patients with COVID-19 have smell loss. First, go over the timeline of how this was first reported, how this kind of tracked across the globe and took us all by storm, whether we were clinicians who were taking care of COVID patients, we were people who, like myself, study and take care of patients who have smell loss at baseline, or just really any human on the planet. I'd like to go over what we know about smell loss in COVID-19, the mechanism by which it happens, so why it happens and why it's different from normal colds. And finally, I'd like to review a bit of the treatment strategies and some of the evidence behind how to treat COVID-19 related olfactory dysfunction or smell loss. So let's get into it. So I know that many people who are watching this may have been clinicians or are clinicians or have studied science, but even if you're not, we're all intimately aware that smell loss happens all of the time. It happens in the setting of common colds. It happens when we pinch our nose to stop ourselves from smelling something poorly. And it's really one of the most common cause of loss of sense of smell is just a normal cold. You get a stuffy nose, you can't smell, that's pretty normal, and it goes away. However, early on in the pandemic, people began to notice that there was an increased incidence of smell loss in the setting of COVID-19. And in particular, the really kind of weird or unique finding about this was that the loss of sense of smell was not accompanied by the standard nasal symptoms of nasal congestion, stuffiness, or drainage. It was really unusual. So people felt totally fine, but they lost their sense of smell. While olfactory loss is certainly common in the setting of common colds, it's really we've all become increasingly aware that olfactory loss or smell loss is incredibly common and highly prevalent in the setting of COVID-19. The lasting impact of this symptom and its actual importance remains to be unseen, but it's something I hope to kind of go over in the talk. So to begin with, let's talk about the history of how this came about and kind of how this kind of went across the globe, became popularized within the media. So very quickly, the symptoms of isolated olfactory loss gained tremendous traction in the mainstream. Reports by the New York Times, by NPR, Goats and Soda, to Esquire magazine, they all picked up on it, that smell loss was an indicator of COVID-19. Within just days of the WHO recognizing that COVID-19 was going to be a pandemic and a global health crisis, there was a tremendous and really kind of just outrageous effort by the world's chemosensory experts that gathered virtually, hundreds of them, and formed a society now known as the Global Consortium for Chemosensory Research. This is something that myself and many otolaryngologists and a wide-ranging number of clinicians and different scientists became involved with in the beginning of the disease. And we all kind of put our heads together, had a gigantic Slack community where we could all communicate with each other and kind of figure out why and how this happened, and really kind of what are some of the implications of this and how to treat it, and how this is going to affect people over the long term. And it's something that continues to be quite robust and strong today. Meanwhile, multiple other organizations were founded for the simple and sole purpose of figuring out why smell loss happens in COVID-19. So this is an example of a nonprofit organization that was founded in the UK. And even our own Academy of Otolaryngology, American Academy of Otolaryngology, created a tool to detect for clinicians to use when this symptom came about, when patients had COVID-19. So it didn't matter whether you were seeing an internal medicine doctor, you were seeing an otolaryngologist or an ENT, or you were just reporting it kind of on your own as a patient. There was access to a lot of different tools to kind of capture these different symptoms, which is really, really important in the absence of, if we all remember, we couldn't get tested long ago. Testing is now something that's very common in our lives. In the first months of the pandemic, it was something that was not readily accessible to everybody. So basic tools like these were incredibly important. So by the numbers, as COVID-19 kind of marched across the globe, starting in Asia, going to Europe, and finally coming to the US, it appeared that anywhere from one half or 1/3 of the population to a much higher percentage had problems with anosmia, which is complete loss of smell, or olfactory dysfunction. Many of these reports were first anecdotal, but in South Korea, they first noted that 1/3 of their patients who had a confirmed diagnosis had anosmia, self-reported anosmia, that is, so patients said that they couldn't smell. In Germany, up to 2/3 of the cases, and in Italy, about 60% of patients had symptoms prior to their hospitalization, meaning that perhaps it was an indicator of disease. And that's what really kind of got the wheels turning and people started to wonder and frankly kind of worry about. Then in a really nice done multi-center European study of 12 different institutions, they found that a whopping 86% of patients had olfactory loss and 88% had gustatory symptoms. Gustation is the sense of taste. So 86% had some sort of smell loss, 88 had some sort of taste loss, or patients reported it anyways. And again, chemosensory symptoms, which is smell and taste loss, were first to begin in about 12% of patients, again, suggesting that perhaps these symptoms were an indicator of disease. Again, as I mentioned in the beginning, many of these patients, almost 1/5 of the patients, didn't have any additional symptoms. They didn't have a stuffy nose, they didn't have nasal drainage, they didn't have any other real complaints. It was just the changes in their sense of smell or the changes in their sense of taste. And then in a particularly tremendous effort, in a UK-based survey and app, again, this is in the first months of the pandemic when testing was not available, when we were in the heart of lockdown, this UK-based app surveyed 1.6 million people over the course of 5 days. They found that there were 1,700 confirmed or diagnosed cases. 60% of them had olfactory loss. Again, keeping in mind that testing wasn't available, this bright group of scientists was then able to use some backtracking statistics to figure out how often smell loss occurred in their population. They could calculate things like the sensitivity and specificity of that symptom, meaning how likely of a predictor is it that you have a COVID-19 infection. Then they could calculate how many people in the population were already infected. And this was really important, especially in the times when hospitals were full, healthcare resources were overwhelmingly stretched. And again, testing wasn't available and we were in the height of lockdown. So now, kind of getting into it, this was a really exciting publication that came out towards the late spring, early summer of the height of the initial outbreak of the pandemic. And this was a study done out of Iran. And the reason that this study is so important is because I've been saying that smell loss in all of these prior studies has been self-reported or patient-reported. And I'll talk about it a little bit later. But self-report, we humans, we're really not too good at identifying how our sense of smell is. You can't tell me your sense of smell is great or it's a score out of 10. You know, my sense of smell is an 8. Just like you can't guess your blood pressure, you can't tell me what your sense of smell is. You may have a global picture of how it is, yes, if it works or it doesn't work, so yes, no kind of things. But having a range of smell function is really hard to know. And so this study out of Iran tested 60 patients who were hospitalized with COVID-19. They found that 98% had some degree of smell loss using the UPSIT, which is a more objective test. And this was the first test to say that almost all patients who have COVID-19, whether they reported it or not, whether they told you that they had symptoms or not, they did manifest symptoms of smell loss, which was, this was a vital piece to the literature and our understanding of this. So then there's been a couple of different meta-analyses. Those not familiar with the scientific literature, systematic reviews and meta-analyses, they are really nicely done studies generally that take all of the available evidence and they synthesize it into one succinct document. And the first meta-analysis that came out on this that reviewed subjective only, so self-reported smell loss only, showed that there was a range of smell loss in 5 to 98% of patients. So a really kind of wide range of smell loss. And similarly, taste dysfunction was similar, about 5 to almost 93%. There was a bit to improve on it. And so there was another systematic review of meta-analyses that came out about 6 months later. And it showed the numbers there highlighted in yellow, that the prevalence of smell loss in the setting of COVID-19 in when psychophysical tests, these are ones that actually allow patients to do a test, which involves either a scratch and sniff test or smelling pens or any other different ways, and it gives them an actual score. This systematic review with meta-analysis demonstrated that in 77% of patients with COVID-19, there's some degree of smell loss, which is substantial. So needless to say, there are a lot of patients who have smell dysfunction in COVID-19. And we're talking about now is the acute period. And as many of you, I'm sure, are aware, there certainly are patients who have this kind of over a longer term, which I'll get to in a moment. So why is this important? I've just spent the past 11 minutes here telling you about the prevalence of smell loss in the setting of COVID-19. And so many patients think, and many humans just in general think that, smell is kind of an overlooked sense and it's really not that important. What would you rather have? Would you rather have vision or would you have your sense of smell? And generally people would choose vision. They choose their sense of hearing. However, there are many reasons why this is important. The first one was that this was incredibly personal. So again, I'm an otolaryngologist or an ear, nose, and throat surgeon. I have a special expertise in sinuses and endoscopic skull-base surgery, which means that I'm a guy who operates or deals with patients who have issues with the olfactory nerve. And so when my sister, who is a nurse, developed COVID-19, and she was chopping onions, and she wanted to know when she could smell them again. This was certainly a concern of mine, and so many of my close, certainly many of my patients, but many of my close family and friends develop issues with smell loss. And so why am I worried about it? Well, it's really important because smell is incredibly vital to human life. It's something that we overlook and we take kind of for granted until we lose it, like many things. And so it's vital to our well-being. It's vital as humans. We really enjoy eating. We enjoy food. We enjoy Thanksgiving. And it's not just Thanksgiving eating the food, it's mom with the turkey in the oven. It's the anticipation of eating, it's being around family and friends, it's smelling loved ones. And so it significantly affects our well-being. Patients who lose their sense of smell, they have issues with social interaction. They're more likely to become depressed. They're more likely to have symptoms of anxiety. This is notable. And although it is overlooked, we know that it significantly impacts our patients. We know that there's a dose-dependent relationship. So the higher the degree of smell loss, the more likelihood you are to you have an increased risk of mortality. We don't know why this happens. Actually, this is something that's been well popularized over the past 10 years or so. But smell loss is actually a better predictor of your overall mortality as compared to other chronic conditions or neurologic diseases. So things like heart disease, for instance, we know is a substantial is a substantial killer of Americans. It takes years of our lives. I think everybody would agree with that, and the science would certainly support that. However, if you look at the numbers and you compare the patient, you look at frank olfactory loss as compared to heart disease, loss of sense of smell is actually a better predictor of your overall mortality. Again, we don't know exactly why this happens. It may be that smell loss is an indicator of how your nervous system works. But it's something that many scientists, especially in the setting of COVID-19, now looking towards approaching 2 years, that has certainly interested many scientists and many practitioners as well agree that this is incredibly important. So why else is this important? Well, again, at the beginning of the study, at the beginning of the pandemic, testing was not widely available, and still testing isn't necessarily always practical. And sometimes, using clinical indicators is really important to figure out how to treat somebody, how to take care of somebody, how to potentially isolate somebody or quarantine somebody. And so it turns out olfactory loss is actually a really good indicator of disease. And so many patients who present with COVID-19 have many similar symptoms to the flu, for instance, so influenza. And so really nicely done study out of UCSD that came out in the summer of the first year of the pandemic, demonstrated that the odds of smell loss in the setting of COVID-19 were significantly higher than patients who were admitted to the hospital with the flu. And this, I think, is an important factoid that will probably be important for us for years to come. It might help us to identify. And so, if you are waiting to go see your doctor, for instance, and you say that you have smell loss, maybe you have COVID, maybe you have another virus that causes smell loss. And that may be important in characterizing which patients we're coming across. This study was also really important because it told us that about 75% of patients who had COVID-19, who tested COVID-19 positive, they had improvement of their nasal symptoms at the time of their clinical resolution of their illness. So this was one of the first studies that showed us that not all patients who lost their sense of smell with COVID were going to lose them forever, but 25% of patients who stopped feeling kind of sick otherwise, they continue to have symptoms of smell loss. And that's the other, if you take this fact and turn it on its head, you can read that it says that 26% of patients still had smell dysfunction once they had clinical resolution of their illness. So once they started feeling better, they still had a smell problem. Another reason why this is important, going back to our global chemosensory consortium, the group of scientists and physicians who are all kind of working together, as it turns out, we surveyed over 4,700 patients in 23 different languages, and we found that smell loss is actually the most predictive of having COVID-19. So of all the symptoms that you can have, whether you have fevers, chills, cough, body aches, general malaise, stomach upset, loss of sense of smell is probably, as it appears, the single best indicator that you actually have COVID-19, so sudden smell loss. Another way that was really important, this was widely popularized by the New York Times, was this article here. And this is a really, really interesting study that used Google search terms to track the disease from place to place and kind of figure out where it was going next. And so again, testing was not widely available at the beginning of the pandemic. If you look at the date here, the date is April 5th, 2020 on this article. And so this is still normal. And if you remember, at the height of the pandemic, what was the city that was most affected? Well, that was New York City. And so on the y-axis, there is search popularity. So how many Google searches were done for smell loss. On the x-axis is how many cases per 1,000. And the search was for loss of smell. And so you could see that the more common there was the search term for loss of smell, the higher the likelihood of COVID being in that area, the higher the prevalence and the incidence of COVID. So New York, New Jersey, Louisiana, all the places that were most affected by COVID-19. Now, some people may say, well, this was becoming widely popularized. You're going to say, hey, Nick, you just showed a bunch of articles that said that smell loss was accompanied by COVID-19. It's just people know that they're getting sick, and so they're looking it up because they're interested in it. Well, actually, the Italian data is really interesting. So if you look at the Google search term in Italian that says, I can't smell, you can see that there was a spike in search terms for I can't smell even before the first report of COVID-19 being a symptom was produced. So I found this, incredibly interesting. And this was published in the New York Times, not exactly a peer-reviewed journal. However, this has since been published quite widely and impressively in peer-reviewed journals. So there's been a few publications on this, one which is represented here. I'm sorry that the graphics aren't more clear, but this is the highest quality image that you can get even from the journal itself. And what this image shows, this shows trend lines with search terms for smell loss, followed by number of cases, followed by number of COVID-related deaths. And so this shows that they kind of go hand in hand. So as the search values for smell loss go up, the cases go up, subsequently followed by the number of deaths, which was really quite striking. Another reason why this is important was picked up by the US military. So my brother-in-law works for the US Air Force, and he was stationed in South Korea during all of this. The US Army had used the unique symptom of loss of sense of smell as a screening measure. And so what they were doing at US bases in the absence of being able to widely test everybody, what they were doing is they were assessing patients' sense of smell to apple vinegar as they drove onto base to make sure that they weren't COVID-19 positive. Unfortunately, apple vinegar is a trigeminal function. The trigeminal nerve is what gives you your sense of touch. And so when you have like a hot chili pepper and it kind of burns your mouth, or you kind of feel it in your nose when you have menthol when you're chewing it, and you have that cool sensation. Vinegar kind of works the same way. It's not really the best odorant. So perhaps they should have consulted a smell expert before doing this. But nonetheless, I think it's really kind of an ingenious idea, and something that really could have been done a bit more broadly if there was a way to practically do it. Next, here at home at Hopkins, we've been playing our part. This was early on in the pandemic, every single day, and I clicked mine a few hours ago this morning. We have a screening prompt that pops up onto our computer, and you can't do anything until you check in to make sure that you're not sick. And so Hopkins recognizes that this is a cardinal symptom of the disease. And if you have sudden loss of smell or taste, then that prompts you to perhaps get a COVID test or stay home. So why does this happen? Again, I commented on the beginning, many of us are well aware, whether you're a clinician or you do anything else that is not a physician, we all know that loss of sense of smell happens really commonly in cold. And so why does this happen? And why does it happen in the absence of congestion or a runny nose or kind of nasal blockage and the normal stuff? And why doesn't it come back? In some patients, it doesn't. And so I think it's important to take a step back and have a quick primer on the different causes of olfactory loss. So there's three different causes. So the first one is the conductive cause, and this is the most intuitive loss of sense of smell, reason for loss of sense of smell. And so this is that very simply, an odorant can't get into your nose and go up to where it needs to go. So if you hold your nose, if you pinch your nose, and you don't want to smell something, you have a temporary conductive loss. If you have lots of nasal inflammation, nasal swelling because you have a cold, a virus, or if you have something like nasal polyps or chronic sinus infections, the odorants can't physically get up into the nose, which is about here. It's by the about by the bridge of the nose where that nerve lives. Can't physically get up there to bind to the receptors, that the nerve receptors that live there. So that's one cause for loss of sense of smell. Again, the patients they're not really having congestion, nasal blockage, and the normal symptoms. So we need to start thinking about the other losses of sense of smell, the other reasons to lose sense of smell. And the second one is called the sensorineural insult. And that means that there is a direct insult to the nerve itself. So perhaps the nerve in the nose is targeted, or the area where the nerve lives is affected by the virus. And similarly, as you get older, unfortunately, like many things, just like my gray hair is coming in, just like the glasses I wear when I'm seeing patients, things they don't work as well necessarily as you get older. And the nose is unfortunately no different. And so as you age, we do know that there is a overall loss of sense of smell. And so it could be age related. And then there's also central issues. So central issues means the central nervous system or problems with the brain. And so if the signal is coming from below and it can go up to the brain, but the brain's not working right, then that can also be a potential cause of loss of sense of smell. And so all three of these different categories of olfactory loss have been argued for in the setting of COVID-19. And so one of the first really interesting case reports was a case report that came out of France. It was published in JAMA, the Journal of the American Medical Association, JAMA Otolaryngology. And it was a 40-year-old woman who had body aches and a dry cough, who presented with complete olfactory loss. And she said that she had loss, and then they tested her with one of these scratch and sniff books. And sure enough, her score was, no pun intended, or maybe it is, it stinks, or it stunk. It didn't really work. And so they imaged her. This is a CT scan over here on the left side of your screen. Those arrows are pointing to the area where the olfactory cleft is. The MRI, which is the next two pictures on the right, right here, shows that there's some inflammation that's isolated to the olfactory cleft. And so that is where a special lining of the nose lives. It's called the olfactory epithelium, and the olfactory nerve kind of goes into that area. And so this was a sign that perhaps there was unique inflammatory changes in that area alone. The rest of the nose actually looks pretty normal on that CT scan and MRI. And then it's worth noting, without getting into the science too much, that SARS-CoV-2, the virus that causes COVID-19, it needs to bind to an H2 receptor that we as humans kind of have all throughout our body. It's in many different places. It's the angiotensin converting enzyme 2, again known as ACE2. And we know that this is important. It was widely popularized in the media at certain points during the pandemic, and the certain news stories, that this was a really, really important receptor. And it's perhaps how the virus gained entry into the human body. And so we studied this along with several other groups, looking at the number of ACE2 receptors and the distribution of ACE2 receptors in the airways, because we know that that's how we get sick from these respiratory infections, whether they are in your nose or they're in your chest. They have to enter either your nose or your mouth, right? And so there's been several studies that have looked at kind of human-wide, genome-wide prevalence of these receptors, and then a study that we did on our own, where we took biopsies from the nose and we took biopsies from down further in the airway, in the trachea. We found that there was a 700-fold higher expression of this ACE2 receptor in a specialized cell called the sustentacular cells that live in that olfactory epithelium that I showed on the previous slide, kind of showing that inflammation in that area. So lots more ACE2 receptors in the nose as compared to the tracheal mucosa. This is Mingfei Chen. He's from Dr. Annie Lane's lab here at Hopkins, who I've been fortunate enough to collaborate with and publish this report on. Really kind of tremendous stuff. And so another reason why this is important is because with this kind of information, there's been several animal models that have demonstrated that perhaps the coronavirus, different coronaviruses, and COVID-19 is a coronavirus, can directly infiltrate the central nervous system, aka like your brain and your spinal cord, through the olfactory nerves or the olfactory bulb. And so many authors have questioned exactly how this virus gains access to our bodies. These receptors are also found in our brains. And so, there's some really interesting theories out there. I think that the verdict is still out exactly how it gets systemically through our system. Certainly, there are many, many different ways of which it can gain access, but the nose may be entry, serve as a kind of unique entry point into the human body. And so it's something that many scientists and investigators are certainly looking into. Another reason why this is important, and finally, kind of bringing it home to our patients and the people that we know and we love. And again, this is a pandemic, and so it doesn't matter whether you're a treating physician like myself, or an ER doctor, or an ICU doctor, or really kind of any physician out there. We're all affected by this, and so there are people that we know. We may have gotten COVID ourselves, and there are many patients who have lasting smell loss. And even if the overall percentage of patients with COVID-19 have lasting smell loss, given the tremendous number of patients that have COVID-19, the total number of patients or persons that are afflicted with this is really kind of incredible and substantial. The sheer number would be huge, even if a small percentage of all the persons affected with COVID-19 had a lasting smell loss. We do know that of patients who have this long haul or long COVID symptoms, that they have issues with smell loss. And as I mentioned in the first slides that I showed, smell loss has really kind of potentially devastating impacts on patients, leading to issues with malnutrition, the inability to enjoy food, the company of others, depression, anxiety, and as I said, there's a really interesting and notable correlation with your mortality and smell loss. And so it's something that I take seriously, and certainly patients who have smell loss do as well. Ultimately, more work needs to be done to figure out how many patients how many persons the smell loss is long lasting in, how much it gets better, and different ways to treat it. I think that's really important, and the area where perhaps we have the most potential growth for, because I will submit to you that there are many parties working on the questions that I have posed to you in the first couple of sections here. But the area where we have the most potential room for growth is how to treat it. So olfactory loss, how do you treat it? Well, I will submit to you that, like many neurologic conditions, treating smell loss, which is how you should think of it, is really pretty challenging. As a sinus surgeon, this is something I deal with on a daily basis. In some cases, intentionally, as an intentional side effect of surgeries that patients undergo with me, they have loss of sense of smell. So something that I'm keenly aware of, and something that I have tried to treat, and something that it is certainly humbling as a physician to take care of. But the first thing you need to do when considering smell loss treatment is you really need to detect it and diagnose it or treat it, to treat it, excuse me. And this is, as I gave an anecdote before. So self-reported smell loss is not reliable. And so we need kind of more objective tests. And so psychophysical assessments, what they are taking a person's perception and essentially putting it down on a piece of paper. So having a patient do some sort of smell test and putting a number on it so you can classify that. And this is imperative to the treatment of smell loss, to figure out how much smell patients have lost, to figure out what kind of smell loss they have. There are different types of smell loss. And some patients with COVID-19, for instance, they have essentially a normal sense of smell, but they may smell funny things, or they their sense of smell may be distorted, and so perhaps everything they smell is bad. You know, some people report that it tastes like rotten meat or it smells like gasoline. Their sense of smell is distorted. And so the first thing I always instruct patients and friends and physicians alike is to do some sort of testing. And this is really challenging during an acute viral illness. So everybody listening to this webinar knows that if somebody has COVID-19, the first thing you want to do, you want to make sure they get better. The second thing you want to do is you probably want to stay away from them. You don't want to get it. And so detecting smell loss is challenging because, you know, we don't want to really, how do you smell? Well, you can't have a mask on. You need to have your nose and your mouth exposed. And so it needs to be done safely, first and foremost. And so there's a few different ways to do this. Objective smell testing. These are the psychophysical tests that I was referring to. There's quite a few of them that are available. I put kind of the three most common ones here, and I'll go through them, all three of them briefly. So the brief smell identification test, or the BSIT, is simply 12 scents, and you can it can tell whether, essentially, it's a kind of quick and dirty test to tell whether a patient can actually smell or not. And so it's a quick kind of scratch and sniff book, and you get generally a binary score. So yes, they have smell loss. No, they don't. It kind of works. The rest of it is kind of gray areas. You don't really know whether it's mild, whether it's severe. It's not the most kind of detailed metric available. Next is the University of Pennsylvania Smell Identification Test, or the UPSIT, which is 40 cents, which is what the BSIT was created from. And this 40 cent test is actually incredibly well done. It's been something that's been around for many, many years. It's kind of the mainstay of what we do in our clinical testing in the office. It's what we have here at the Johns Hopkins Sinus Surgery, the Johns Hopkins Sinus Center, and it's what we use clinically. And these 40 cents, they have been normalized across thousands of patients over the years, across the different sexes, because we know that there's differences between males and females. Generally speaking, females have a better sense of smell, and generally speaking, your sense of smell gets worse over time. And so this is normalized for that. And so we can perform, or physicians can perform the UPSIT test and kind of figure out where they are in a range of normal functioning, mild smell loss, moderate, severe, or complete anosmia, again, total loss of smell. And finally, the sniff and sticks test is a very interesting test that is 48, is 16 different scents that are exposed to a patient in 48 kind of different tests or different ways. And what it does is it measures threshold, discrimination, identification, and a total TDI score. I think this is a really interesting test because it kind of differentiates and breaks down smell loss into three different categories. So it tells you what's the lowest concentration of odorant that you need to be exposed to in order to pick it up. So, you know, many patients will tell me that they are, quote, they can smell like a bloodhound. And so they're telling me that their threshold is really low. But perhaps my COVID patient, they can still smell, but they can only smell if they get it to the front of their nose. They have a really high threshold score. Discrimination is the ability to distinguish between two different scents. So if perhaps I gave patients cinnamon and nutmeg, two different scents, and I asked them to tell me which one was which, that's your sense of discrimination. And if I gave them just nutmeg and I said, hey, tell me what this is, that's identification. And I think that certainly for scientific purposes and figuring out the importance of sense of smell with different conditions and how to treat sense of smell, identification scores are really important when considering the treatment of olfactory loss. The first two tests I mentioned, they're, again, identification tests, it says in their name. And that's kind of more of a gross metric, and it's frankly a bit more practical and easy to do in clinic, and so that's what we oftentimes do. But the sniff and sticks tests are certainly valuable in certain situations. Now getting into treatment. So social media has only become bigger while during the COVID pandemic. And so I did a Google search results. I did a Google search this morning. Today is October the 5th, 2021 at 8:33 this morning. This is what I came up with. So does burning an orange bring taste, smell back from COVID? Well, I would submit to you that this theory has not yet been peer reviewed, and maybe Google search results are not necessarily the best place to seek medical advice. But as I'll demonstrate here, perhaps it is growing a little bit of traction. And so this is a New York Post article from April of 2021, talking about how COVID-19 survivors regain their sense of smell thanks to magician perfumers. I think it's worth noting that magician perfumers cost $650 a session, but perhaps she is onto something. And what we did at the beginning of the pandemic, this already being an interest of mine and something that we knew that we would have a huge number of patients to be treating with smell loss. What we did is we reviewed as a group every single piece of literature that's ever been published on post-viral olfactory dysfunction, or smell loss after smell loss after a viral infection. And what we did was in a rigorous process following evidence-based guidelines, which is really important. We reviewed all of that available literature, and we found that a recommendation for smell loss was olfactory training or smell training. And so perhaps there is some credence to the sniffing things, as the past two slides have alluded to. We also found that perhaps there's an option to use topical steroids, which are a little bit more rigorous than things like Flonase, but using a steroid medication in a rinse bottle, or even a short burst of oral steroids like prednisone, something like that, could be an option for the treatment of smell loss in patients with COVID-19. However, it's certainly worth noting that these should not be used just on their own, and you should really consider the side effects of these potential medications before using. But nonetheless, it was a recommendation that patients who have losses of the smell following a viral infection perform smell training or olfactory training. So how do you do it? Well, here at Hopkins, we have a smell training protocol that we give our patients. We give our patients a weekly journal. We give them instructions. And the most common way of doing this is to purchase essential oils. Essential oils, I'm not really sure that they necessarily have, going back to the previous slide, necessarily magical properties, but certainly they do have a strong odor to them. And so, they're really strong odorants that may perhaps stimulate the olfactory system. And so what olfactory training is, and we outline it here in a pamphlet that we give to our patients, is it's a way to stimulate the olfactory system. And so much like after having a stroke, you would go to rehab to regain your strength, or if you had a knee injury and you needed to kind of work your way back up to get stronger, you would do some sort of physical therapy. So this is kind of like physical therapy or rehab for the nose. And so just like curling a 3-pound weight can give you tone in your bicep, repeatedly smelling different odors can improve your sense of smell. And this has been demonstrated with several different etiologies of smell loss. There are multiple different studies of this ongoing with patients with COVID-19. And so our basic premise here is to give patients about 4 to 6 different odorants. We tell them to repeat it a couple times per day. It takes approximately 2 minutes at each interval. We have our patients fill out a weekly journal or a weekly log, and they look at different images while they're doing this to kind of stimulate their their central nervous system, to really help them kind of get in the moment and think about what they're doing. And so this is as a surgeon, generally I'm talking about performing surgeries. I'm talking about giving medications. This is a little bit different, but again, it is the highest level of evidence that we have for treating patients with olfactory loss at this point in time. It's not a quick fix. It's not something that happens overnight. I tell all my patients that at minimum, you need to do this for 3 months. It's something that takes a bit of work to get into. But again, many patients do find meaningful improvement from this. So whether you're on the call, or you're on the webinar and you're a physician or you're exposed to patients, or you're just kind of somebody who's hanging out at Hopkins at home on a Tuesday at noon, I think that this slide is still pertinent. So if somebody has a sudden loss of smell or taste, again, some sort of chemosensory disturbance, I think it's worthwhile as a take-home message from this lecture to consider them suspicious for COVID-19. Certainly, you can consider alternatives like seasonal allergies, common cold, or if they have nasal polyps or something like that, or they had sinus surgery and they can't smell, that makes sense. However, a unique and sudden loss is something that should kind of set off the alarm bells. And so, number one, you should get a patient tested. I think it's important that a certain number of patients, especially those patients who have prolonged loss of sense of smell, they should be evaluated by an otolaryngologist. They should be evaluated by myself or somebody who takes care of patients with smell loss. And we should look in their nose. It's not very challenging or difficult to shine a flashlight or put a little camera up somebody's nose and take a look around. The UPSIT, that University of Pennsylvania smell identification test, takes about 10 minutes to do. It's easy to do in the office. And so you can have patients, after they get over their acute viral illness, you can have them do that in the office or in the clinic and evaluate their sense of smell to kind of see where it's at, establish a baseline. And then as far as treatment goes, you guessed it. So I counsel all my patients to start olfactory training or smell training. And in certain indications, I do put them on a steroid rinse, nasal wash with some steroids in it. But again, only after careful consideration. It's never too late to start olfactory training. It's a simple intervention with low side effects, low risk. The biggest risk is that you smell something. And so I certainly think that it's a worthwhile endeavor. The biggest issue is probably just staying compliant with it, remembering to do it. And so I counsel everybody that you put it by your nightstand and you have it readily accessible to you. So in summary, I presented a lot of information about olfactory dysfunction or smell loss in COVID-19. This lecture has changed quite a bit from March of 2020 to current day, and then the information is constantly evolving. We're in an era right now where information is readily accessible. There is increasing availability to things like preprints. So articles come out before they're scientifically reviewed, and the process is also fast, even for peer-reviewed journals. It's coming at us faster than really we know what to do with, and it's really substantial, and it's helping us kind of get closer to the truth. And I think that we are getting there. But nonetheless, even though we do have this kind of feverish publication rate, we do need more information. Again, I think key take-home points here are that COVID-19, it's unique in that it is isolated. So patients present without the common symptoms of nasal congestion, nasal blockage, and they have smell loss. It is also perhaps interesting in that many patients have persistent smell loss. And so this is something that, again, we will continue to pay close attention to in the future. So our long haulers, are they the ones with smell loss, or is it other patients who just have smell loss alone and are not having other symptoms? I don't think we know the answers to these questions yet. There's been some suggestion that perhaps smell loss is more prevalent in milder disease. So our younger, more healthier patients are perhaps more likely to have smell loss, and that may be true. It may also be that patients who are more critically ill, they don't complain about smell loss, they complain about shortness of breath or inability to breathe. You know, it might be something different. And so I don't think we necessarily know that either yet. The long-term implications still are unknown. We will know more and more about this as years come. There's been multiple National Institutes of Health awards on this, and it's a hot topic in research. And certainly smell training has been shown in the past to be associated with improvements in olfactory dysfunction or smell loss. And it's something that I will continue to encourage my patients to do. Again, as I mentioned with the basic science slides, there are certain targets, certain molecular targets that live in the nose that may be quite provocative to consider targeting for treatment strategies for COVID-19 and or even for smell loss, things that we need to regenerate or focus their therapies on. And with that last point, I'd like to thank everybody for their attention. I'd like to open the chat box to questions. Feel free to ask them there, and I'll answer them as they come across. So the first question is, do COVID variants result in different degrees of olfactory and or gustatory loss? So a couple of points there. So we are seeing, and I don't think we have the data on it yet, that there probably is some difference in the degree of olfactory loss between the different strains. So right now, we've been seeing a huge number of Delta cases, and it is anecdotally, I don't know the data offhand, I suspect this is probably coming out sometime soon, that smell loss is less commonly reported. But again, I haven't seen that in peer review yet, but I suspect that my, kind of the anecdote is that yes, it does cause, there are differences in the different variants. I will also submit to you that although I didn't really cover it, I should really have put a slide in there, is that taste loss, even though patients report it, about 90% of what we experience as flavor is from our sense of smell. And so in many cases, there's not, when you do a similar kind of psychophysical test, when you do an actual taste test on patients, they don't necessarily always manifest actual taste disturbances, but rather they have smell loss. And there's been many really well done studies out there of patients who present for taste loss alone to smell and taste clinics. And when you do all of the rigorous psychophysical testing, you can do sniff and sticks on them, you can do taste strips on them, which is the sniff and sticks equivalent for taste testing. It is most common that those patients with isolated symptoms of smell loss, isolated symptoms of taste loss, they actually have smell loss. And so the verdict is still a bit out on how much taste loss does happen. There is evidence that some happens, as well as some of that kind of sensation, what's known as chemesthesis. Some of that does occur with COVID-19. Overwhelmingly so, though, I suggest that all patients are worked up for smell loss. So somebody asked, is there a relationship between the severity of COVID-19 and the severity of smell loss? Yeah, really, really interesting. There's been kind of varying reports, and as I alluded to in that last slide, there are in perhaps sometimes in the more severe cases, patients don't necessarily report it as much. And my suspicion, again, this is anecdote, not necessarily science. My suspicion is that those patients are too busy being, they're having challenges with cough and shortness of breath and fevers and feeling really, really poorly to really complain too much about their smell loss. Whereas a young, healthy person who has a robust immune system, perhaps the only symptom they get, because they have a healthier immune system, they have an isolated symptom. And so they have a more mild infection and they have smell loss. And so you got to think about that Iran study that I showed in the beginning. 59 of those 60 patients had substantial decreases in sense of smell as compared to their age-matched controls. And so it's widely prevalent and it's probably there more often than we know. But the issue is that, again, we're not necessarily always testing patients who are acutely ill with their loss of sense of smell. So other than age, are you seeing any geographic or demographic differences in sensory losses? And so I think it's more so the severity of infection that we're seeing it with. Age and sex, I know that there's some differences. I don't know all the long COVID literature off the top of my fingertips like I do the smell data, but I do think that there's probably some differences in the patients who are long haulers. I see many of them myself, and many of them do have persistent smell loss. And so we do see many females with either smell loss or distorted sense of smell. So they have what it's called parosmias or dysosmias, and so a distorted sense of smell, and that's actually pretty common. But geographic ones, not so much that we know of. The reports did change kind of over time when going across the globe, but I think now it's kind of, we all recognize that it is very common. So Aaron asks, will there be research on the impact of smell loss on the aging adult community related to mental health or memory loss? Aaron, that is my favorite question, because before this whole pandemic thing started, that's what I was interested in. It was smell loss in our aging population. And that is something that the National Institutes of Health and I am personally extremely interested in. So the short answer is yes. My personal area of interest currently is looking at frailty and the sense of smell. And so what we've shown from some large population level databases is that olfaction is actually a good indicator of your frailty status. So frailty actually may be a better indicator than age as to how kind of robust your health is and your person is to a stressor like an illness, for instance. And so frailty is really important to clinicians and patients alike. And my personal area of interest is figuring out which of those types of smell tests, like threshold discrimination identification, for instance, which of those is an indicator of frailty, and kind of how does it work? There are many other endeavors that are looking at populations of patients at risk for Alzheimer's and Parkinson's dementia, which both some of the first signs of dementia is loss of sense of smell. And so certainly this is something we're all very interested in, looking at the neurocognitive effects. And I would submit to you that because the smell nerve, which again is sitting right here in our noses, it's one of the only nerves in our entire body that's just kind of floating in the breeze. It's exposed the entire world around us. And so perhaps because it's been exposed to everything that we've all been exposed to, kind of like our skin for years and years and years, perhaps it's a really good indicator of kind of things to come or what stressors we've been exposed to. And so I think there's still a ton of work to be done in olfactory research, and it's incredibly exciting. And for better or for worse, the COVID-19 pandemic has sparked a lot of resurgence in this, in the interest in that. But there are large teams that have been dedicated to this, and it's something that will be focused on in the future. So Nan asks, do ACE2 agonist and antagonist affect loss of smell at all? So that's a very insightful question. And the shorter answer is we don't know. There are, I do know of several ongoing studies of different agents that are being put in the nose to change the sense of smell. I have joked anecdotally with my colleagues that some of the antihypertensive or blood pressure medications could be squirted up the nose to improve the sense of smell. There are some bitter receptors. There's kind of unique taste cells in the nose called bitter taste receptors that can be used in the nose for this. Some people have also looked at vitamin A. There's a study that's going live in the UK, a randomized clinical trial looking at vitamin A for the treatment of this. But I think that's an insightful question that is we'll see the results on sometime in the future. So Courtney asks, how might your work with individuals whose livelihood depends on smell, like a sommelier, how might I work with them in my research? That is an area that is certainly very interesting to me. I think you can think of smell training as what a fancy chef or a sommelier or a wine expert does at baseline. So they have practiced the art of smell training. And so obviously these persons have a vested interest. It's certainly somebody that I have actually thought about partnering with in the future and looking at in particular. I personally wonder what's different about their sense of smell at baseline. And so I think a really interesting question would be to look at healthy patients who have perhaps either heightened sense of smell and or taste, or they just have it kind of honed in like a sommelier, who haven't had COVID, and perhaps see what happens to patients who do get COVID, and then look at some interventions like some of these things we were just referring to, either smell training, rinsing your nose, potentially doing something like vitamin A or other kind of unique and novel therapies that might be out there. So the last question is, for those who are still waiting for their smell to return, what should we eat? Thanks. That's a tough question, and I'm sorry if somebody on this webinar is waiting for their sense of smell to return. Number one, I would counsel you to be patient, and you know, kind of trust it, and seek out help if you haven't already. And I think that's incredibly important. We've highlighted the mental health impacts of losses of the smell, and they're very real, and you should take them super seriously. I believe in smell training. I think the evidence supports it. Again, it's not a quick fix. It's not a panacea. It's not you just take a pill and you get better. It's not like that. And so I'd encourage you to seek help and, you know, do your smell training. And then as far as what to eat, really it's kind of what you want and it's what you can tolerate. And so don't make yourself sick. You know, don't if your favorite food, if my favorite food is asparagus. Many people don't like asparagus at baseline, but I happen to love asparagus. If asparagus is your thing and it tastes like rotten meat now, then don't eat asparagus. Switch over to some other sort of green. Whatever your diet kind of dictates, have at it, and you know, continue to keep working at it and seek help if you need. And so with that, I thanks everybody. Those were really excellent and super insightful questions. It was a pleasure to talk to y'all today, and thanks for having me, Hopkins at Home. And look forward to seeing you at another time. Thanks so much.